Hey guys, this is Miss Buck. We are going to be talking about burns and organ donation today. I think you will find that this information is not as overtly complicated as other topics like hemodynamics and shock, and maybe some other stuff, EKG, rhythms, things like that. But this is still really important information, and we do see it a lot in the ICU. So it's important that we're aware of how things work when it comes to these topics and just how we deal with them as nurses. So these are our objectives for burns. We're going to start with burns and then we will move into organ donation in the latter half of this lecture. Sorry. Okay, so I'm going to start off with just some facts. So burns in the U.S., there are approximately 1.2 million burns annually. 60,000 burn patients end up needing to be hospitalized, and 6,000 burns result in death annually. So, as we can see, 1.2 million burns is a ton. 60,000 hospitalizations is still a lot. And then that's still a very large number of deaths related to burns in the US. So, I know, like, locally, we may not see really, really bad burns. They're probably going to be shipped to your level 1 trauma centers with the burn unit. And in case you did not know, the only burn hospital in Arkansas is Arkansas Children's in Little Rock. It is not UAMS. UAMS and ACH are sister hospitals, and their burn unit at ACH is the one exception to taking burn patients that are adults. So I did, when I did my peds rotation, was in the PICU, and I actually had a burn patient, and it was a sibling set, and it was very, 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 very bad. And it was very horrific. But I do remember there being adults there too, and it just blew my mind. And they were like, well, we're the only burn unit in the state. So just keep that in mind if you end up working in Arkansas, that if you ever have a burn patient, and sometimes insurances won't let patients go to Memphis hospitals because it's across state lines and things like that. So you at some point may end up sending a burn patient to ACH just because they're the only burn unit in the state of Arkansas. So, okay, so a quick little background of what our skin does. So our skin functions, just a little refresh. Obviously, it helps protect against infection and injury. It helps prevent fluid loss in our body, regulates our body temperature, sensory contact with the environment. It metabolizes vitamin D, and it is the largest organ in the body. I'm sure that you guys remember the majority of that from probably A&P back however many years ago that was. For me, it's been 10. So, anyway, that was just a little quick refresh. This is a little diagram of what our skin looks like with all the different organs, sweat glands, sebaceous glands, hair follicles, things like that, just in case you need a refresh. Okay, mechanisms of injury and biomechanics. So the different types of burns that we have are thermal, chemical, electrical, and radiation. So these are just going to be the different types of burn injuries that we can see. So what happens when we have a burn? Burns cause capillaries to become leaky. And capillaries can leak anywhere, not just in burned tissue. So leaking capillaries end up leading or can lead to hypovolemic shock, especially in those severely burned patients. And we'll talk about the rule of nines and burn percentages and stuff here in a little bit. But in those very, very, very severely burned patients, we have a lot of fluid loss because what did I say on the last 2 slides or so ago? It helps prevent against loss of body in or loss of fluid in our body, right? So when we start having a lot of burns, we burn out a lot of fluid. Within 72 hours, 24 to 72 hours after a burn injury is when capillaries are going to start leaking. So early intervention and rehydration and stopping the burn process in these patients is crucial to helping prevent further loss of fluid. So a hypermetabolic state also, it's going to be what happens next. It happens within about that 72-hour time frame post injury. So this is where we're going to see hypotension, tachycardia, and hyperpyrexia. So kind of those shocky type signs and symptoms. And then the long term effects are going to include a hypermetabolism that can last up to or even greater than 1 year post burn, depending on how bad the burn is. Catabolism, which can last 6 months or greater post burn, and then growth delays for up to 3 years post burn. So, this is going to be especially true in pediatric patients who are growing because think of that trauma that's happening to their body. It's just a lot of trauma to a growing, otherwise prior healthy, little kid, and their body's just gone through a lot, so it can delay growth. Okay. So this is just a little bit of a diagram regarding like the coagulation of burns and what kind of happens. So we have the zone of coagulation here, we have the zone of stasis, and then we have a zone of hyperemia. Okay. So we're fixing to start talking about burn depth. So we have partial thickness and full thickness burns. So partial thickness is only going to include the dermis and the epidermis, whereas full thickness burns are going to go all the way through to that subcutaneous layer. So we have scald burns, which are caused by hot liquids or steam that are spilled onto our body. They can be immersed, like a limb can be immersed in a pot of like hot water, something like that. Hot grease really creates some of the worst burns. I'm sure you guys have probably cooked bacon or something that pops whenever you're cooking it, and it burns like crazy if you even get a drop of that. So imagine having an entire pot or something of grease spilled onto you. Imagine how hot and horrible that would be and how bad a burn could be from that. So these are most commonly seen with children and elderly adults, as well as industrial workers and then women or men who are cooking. And then remember, just take every chance for education and prevention when it comes to stuff like this. So with little kids, don't leave handles turned out where they can grab them and pull a pot down on them that's full of hot water. Turn your burners off. Just be aware of your kids. Always take precautions whenever you're cooking to prevent grease fires. Know how to put grease fires out, things like that. Okay, so a flash burn is next, and it is an exposure to brief but intense radiant heat. So, an example, I think of like explosion. So, like a meth lab explosion or a lightning burn pile with gasoline, or lighting a burn pile with gasoline, I'm sorry. Okay, so flame contact is obviously direct contact with burning material. Examples would be fireworks that set clothing on fire, burning leaves that set pants on fire, things like that. Anything, obviously, that has contact with the flame that can be on that person's body that can, in fact, cause their body to become burned. Most of the time, you're going to see clothing be the culprit of a flame contact burn. Okay, so chemical burns, obviously sources are going to be different. Chemical burns can happen from a number of different chemicals. So always be sure that you can, when you can, identify what chemical it was that burned the patient, because sometimes there is a neutralizing agent that we can get, sometimes there's not. But it's always important to identify, obviously, in any kind of situation, what caused the burn so that we know how to treat it, and that can help drive our treatment plans and specialize those to that patient. So obviously chemical burns are going to be influenced by the length of contact, the concentration of the chemical, and then the amount of the chemical. And then our signs and symptoms are probably going to vary a little bit depending on the chemical, but obviously we're going to see redness, irritation at the site of contact, things like that. You may see blistering. Obviously they're going to vary a little bit, but like I said, big thing is to try to figure out what the chemical was that caused the burn, and then how long they were in contact with it, how much of the chemical it was, and then if they know the concentration, if it was 20%, if it was 50%, 100%, things like that. Okay, so electrical burns can be caused by the two different types of currents, our direct currents and our alternating currents. So the most common types of direct current electrical burns are going to be lightning strikes and then contact with like a car battery. So always make sure whenever you're trying to jump somebody off or changing your car battery out that your wires are where they need to go. And when in doubt, just take it to your dealership or something like that so this doesn't happen, because it's very important that you do it correctly. So, alternating currents are going to be like current that is flowing through power lines, or anything in like your normal household, like your appliances. So, any kind of burns that are related to those kind of things are going to be like your alternating current burns. So, some signs and symptoms. The big thing here, obviously, it's electrical. So, cardiac dysrhythmias are going to be the big thing that we're concerned about because what does our heart do? It's full of electricity. That's what sends all of the signals throughout our body and tells our heart to pump and do all the things, right? So, cardiac dysrhythmias are going to be our number one concern just because of the electrical impulses that it can change. So always get an EKG on these patients, and make sure that their heart rhythms are okay. A lot of times they get admitted for 24 hours or so just to make sure that they don't have any EKG changes, really for just like a observation type deal. But it's just to ensure and cross all the T's and dot all the I's that their heart's good. So hemoglobinuria and myoglobinuria is just urine and like the amounts of it, or blood and the amounts of it that are in your urine. So hemoglobinuria is obviously blood in your urine, and the myo is excessive blood in your urine. And this really happens with electrical burns because of the muscle damage that can result from those burns. So we really want to make sure we get UAs and monitor their urine output and things like that, and just kind of be watching for those things. Electrical burns may or may not have entrance and exit wounds. Sometimes they do, sometimes they don't. Everything's different when it comes to these type of burns. If they do know, it's really important, or if you do see an entrance and an exit, that you document that. So your entry wounds are like where your electrical burns happen and the point of contact happens with electrical burns, are usually going to appear kind of yellow, whitish yellow. They're blood deprived and they're kind of coagulated areas, and that is where like your entrance points are going to be. So when you have an exit wound, it's going to be very, very evident that something is wrong. It's usually kind of black. It looks, sometimes it can be a big hole. It very much looks like trauma has occurred. Um, and honestly, internal damage can be a whole lot worse than external damage. Sometimes, like I said, you don't have an exit wound with everything, but a lot of the times you do. So always inspect people's feet, their heads, their arms, their limbs, their backs, things like that. Literally their whole body, especially if they come in unresponsive, and they're like a lineman or something like that. That should be something you immediately start thinking of is electrical burns. And honestly, really with internal damage, sometimes we don't really know the extent of it until we get imaging back. But it can very, very, very much be worse than external damage. Okay, radiation. So this one obviously isn't as common, but it can happen. It's usually just from radiation therapy in cancer patients. You'll see them have radiation burns and things like that. I've never seen anything else with radiation burns other than with cancer patients. Not saying that it can't happen. It's just not as common, and it usually has a cause and a reason. So inhalation burns happen from, or they are common in enclosed spaces, and really our airway here is of the most concern. So common concerns are going to be hypoxemia. We're going to have a reduced infraction of inspired oxygen, asphyxia because of decreased oxygenated blood and increased CO2 in the blood in our tissues, carbon monoxide poisoning because obviously CO2 binds to oxygen binding site or carbon monoxide. I'm sorry, not CO2. Carbon monoxide. So CO binds to oxygen binding sites on our hemoglobin molecules, and that can cause carbon monoxide poisoning. And then pulmonary injury because it occurs when inhaled particles enter the lungs. It can accumulate debris and secretions, and then the sequelae is pulmonary edema and pneumonia. Okay, so now we're going to kind of get into the degrees of burns. So obviously, we're going to start with first degree burns. So the depth of injury is limited to just the epithelium. Wound characteristics are going to be erythematous. They're going to be hypersensitive. They're usually not going to have a blister. And then the treatment course is about 3 to 5 days. Usually there's not any scarring, and it usually heals just fine on its own. Just keep the site moisturized and increase your fluid intake. When we are doing or dealing with first degree burns, we do not count first degree burns when we are totaling up total body surface area. So if you have a patient with multiple first degree burns, we don't count first degree burns in the TBSA. So obviously, like a minor sunburn or something like that is going to be like a first degree burn. So second degree burns are going to be partial thickness and deep thermal. So the depth of injury, so the epidermis is destroyed and there is damage to the underlying dermis. Some of the underlying epidermal appendages may remain intact. Initially, it may not look too deep, but it usually develops over the first 24 to 48 hours. It's usually moist, weepy, pink or red. It can be pale, blanching, hypersensitive, and these are usually going to cause blisters. So our treatment course here is going to be about 21 days with minimal or no scarring. Deep burns will obviously require, some skin grafting to a certain degree. And then good fluid intake and resuscitation is important. So these are an example or some pictures of examples of second degree burns. If you've ever burned your hand on a pot while you're cooking or something like that and you get a little blister, that would be a second degree burn. Obviously, it's very, very, very minor, but just know that they can be very, very rough. Okay, and then third degree burns are what we are going to consider full thickness burns. So the cause of injury here is a prolonged contact with flame, scalding liquids, steam, chemicals, electrical currents, things like that. The depth of the injury, so the epidermis, the dermis, and the epidermal appendages are completely destroyed and they may involve muscle and bone. Our wound characteristics are going to be, our skin's going to be dry, leather-like, pale, mottled brown red. We're going to see some thrombosed vessels. It usually doesn't hurt like the direct site, but the surrounding area can be really painful and it does not blanch. And when I say blanch, like when you press on it, like it doesn't blanch. And then the treatment course is obviously going to be some skin grafting and possible amputations, depending on how bad the extremities and things are. These are going to be your patients who are going to be in your burn ICUs and on massive infection precautions. When I went to the PICU and was in the burn unit specifically, we had to wear the yellow contact gowns and it was 80 degrees in there, obviously because they have no thermal regulation at that point. So we try to keep it very warm. They have a lot of fluids, a lot of pain management is typically on board because the surrounding tissues, remember, and the surrounding areas are very, very painful, but the site itself typically is not painful because everything's just completely destroyed. And they're a very, very high risk for infection because obviously if it's involving muscle and bone, there's just a big gaping hole. So this is an example of a third degree burn. I think these are all Miss Mata's old pictures, and she worked at a level 1 trauma center for 5 ever. So I'm sure she has seen a lot of things in her days. So all these pictures that you guys see, they are courtesy of her because she is very, very experienced when it comes to these types of things. But you can see it's just charred. There's nothing there. And this patient looks darker toned in skin, and that you cannot tell by look at this. Looks like muscle. Yeah, it's rough. Okay. And then, so we do have fourth degree burns. A lot of times you're not really going to hear them referred to fourth degree burns. But fourth degree burn, the term is used to describe burns that extend through the dermal layer and through the subcutaneous tissue into the underlying fat, fascia, muscle, tendon, or bone. So honestly, third degree burns and fourth degree, if you got a third degree, you probably have a fourth degree. But this is really just a term used to um, basically say that it's extended all the way through, like muscle, bone, tendons, all that are involved. Okay, so treatments and assessments of burns. So when we're determining the prognosis of the patient and how severe their burns are, there's three main critical factors that we look at. We look at, are they over the age of 60? Because we know that anything with anybody over the age of 60 is just automatically a high risk. Is their total body surface area burned? So is the total amount of their body burned greater than 40%? And then do they have an inhalation injury to go with it? Because if they've got an inhalation injury, obviously their airway is compromised, and that's going to be a problem, coupled with a greater than 40% TBSA burn. That's obviously problematic for multiple reasons: fluid loss, shock, infection. We've got to do probably skin grafting, amputations. So, those are our three main risk factors for death in determining the prognosis of patients with burns. Okay, so burn unit referral criteria. So second and third degree burns are going to get a burn unit referral if they have a BSA, so a body surface area, should be TBSA, sorry, total body surface area burn greater than 10%. And if they are under the age of 10 and over the age of 50. So TBSA 10% if they are under the age of 10 and over the age of 50. They're going to be automatically referred. And then TBSA of 20% is going to be all other ages. So anybody between like 10 and 40 is going to be those who fall into that category. And then if they have face, hand, feet, genitalia, perineum, or joints that are involved, those are also going to be automatic referrals to the burn unit. With third degree burns, if it's greater than 5% in any age group, no matter what, they're going to get referred. Whether it's electrical, chemical, inhalation injuries, circumferential burns, pre-existing diseases, concurrent trauma, those are also things that are going to drive us to make sure that we get those referrals, and probably to a burn ICU if they are greater than 5% in any age group plus have any of the other things listed. Okay, so the rule of nines. It cut off my little stuff, but it's okay. We'll make it work. So the rule of nines. So this is what we use to estimate the TBSA, or the percentage of burns, and you guys really need to know this. So we use the Palmer method for small areas or patchy areas. So a patient's palm and fingers equal about 1% TBSA. And we, like I said, don't count superficial burns, so those first degree burns, into TBSA. So children and adults are a little bit different when it comes to burns. So children are going to be the front and back of their head is going to be 18% total. And then their back is going to be, so their back is going to be 18%. Their chest is 18%. Right and left arm are 9%. Both legs are 13.5. I know it cut off the left leg, but both legs are 13.5. Both arms are 9%. Chest is 18, back is 18, and then the front and the back of the head are 18. And then the perineum is 1. On adults, obviously our legs are a little bit bigger, so they account for a little bit more of a percentage. So right and left leg for adults are going to be 18% each. The perineum is going to be 1%. The right and left arm are 9%. The back is 18%. Okay, sorry, I paused it for just a second and fixed the picture. Okay, so the front and the back of a adult's head is 9%, their back is 18, their chest is 18, right and left arm are 9% each, perineum is 1, and the right and left leg are both 18%. So when I'm talking about head, front and back, it is total, like the front and the back total are 18%. So on a child. So if you've got a kid who's got just a back of their head is completely burned, it would be 9. And the front of it's completely fine, it would just be 9%. If it's front and back, it would be 18. Same with an adult. So if the front is completely burned, it's just half. It would be what? I think 4.5%, if I'm doing that right. It's late and math is hard at this point, but I think 4.5 is right. 4 and 4 is 8 and half is 1. So yeah, 4.5%. So I just wanted to clarify that because I know that can be kind of confusing. It's the total amount for the front and the back. So if it's just half of it, then it's just half of what the percentage would be. Okay, so on an initial assessment, we've got a primary survey and a secondary survey. So obviously our primary survey is going to be our ABC, so airway / C-spine, breathing, circulation, and then a neuro check. And then our secondary survey is going to be a head-to-toe survey, and then we're going to rule out any other associated injuries. So some pertinent history, obviously, like I said earlier, the mechanism of injury, so the cause, what caused it, if there's any smoke inhalation involved, so we know for airway purposes, if it was a closed space, if there was a noxious chemical, and if there is any associated trauma. Also, we want to, at this point, get a medical history if we can, know if any meds or alcohol were involved. Meds also include illicit substances. If there's any pre-existing diseases that the patient has, what's their past medical history, things like that. Do they have any allergies, and are they up to date on their tetanus shot? Obviously, with the airway assessment, we want to provide 100% oxygen, especially if we know that there is airway trauma involved. So a non-rebreather mask or a other well-secured airway would be appropriate. Liberal intubation is very much what we utilize here. So if the patient has sooty sputum, if they've got rales, if they've got rhonchi, if they're hoarse, we're probably going to intubate them just because their airway is compromised, and it's just a matter of time before they stop protecting their airway and they crash, and we can't intubate them, and we're having to emergently crike them at bedside because their airway is swollen shut and inflamed and irritated. So when we're doing intubations, obviously we want to ensure proper tube size and accurate placement. Respiratory is usually very good about making sure that the proper tube size is used. Usually providers are really good about that too. And then obviously get a chest x-ray to confirm placement. We really want to get an ABG set too here. And then a carboxyhemoglobin, we want to keep it under 10. So history, are they unconscious? Were there noxious gases or fumes? closed space, facial burns, singed nasal hairs. People often forget about this, but singed nasal hairs can sometimes be the only thing that people see on an assessment, and it can be a very rough, or I don't want to say rough, it can be a very useful sign for us when we are assessing because the patient can be way worse than what we realize. So singed nasal hairs, especially if they're coming from like a house fire or something like that, like always assess for those types of things. If they've got a rapid respiratory rate, if they're flaring their nostrils, and then if they've got any kind of retractions, these are all going to be really important to know because they're going to guide us in helping to know whether we need to intubate and how their airway is at the time. Sometimes these patients do need a bronchoscopy. If we intubate them, a lot of the times they will perform a bronchoscopy at bedside because you just drop the camera just down the ET tube and respiratory's in there, and it's not a hard thing to do, but it's a little bit easier to do once they're intubated and you can see stuff better and their airway is secured. Oops. So obviously we want to do a breathing assessment. This kind of goes in with our airway assessment. What is their ability to ventilate and move air? We want to rule out any chest circumferential burns, so any kind of like chest burns, and then rule out respiratory embarrassment or respiratory complications. And then sometimes they do have to perform a chest, I'm going to butcher the word, escharotomy. And I think that that's what this is up here, just to relieve pressure and things like that that happen from certain burns. Okay, so circulation. So we want to insert 2 to 3 large bore IVs. These patients, especially our severely burned patients, are going to be getting rapid fluids. We're going to be slamming some fluids in them because they need it. AC is the preferred vein. They may access burned skin. LR is the fluid of choice, and we want warmed fluid. LR is the fluid of choice because it's got some extra electrolytes and stuff in it that's going to help balance out their electrolyte imbalances from the fluid loss a little bit better. Warmed fluids are important because why? What's the skin do? Regulates our temp, right? So if we start shoving just random colder fluids into somebody, into a patient who's already probably shocky, we're probably just going to shock them even further, and it's liable to end up making them code or something like that. So always just put in warmed fluids with these patients. A lot of the times lab will keep some fluids warm to ERs. A lot of the times too, or not lab, blood bank. ER, a lot of the times too, will have a warmer for fluids specifically for trauma patients. And then we want to get a CVL or a CVC, central venous catheter, if there's a large burn, obviously. And then the other thing is to use a Doppler to assess for pulses because we need to make sure that we've got adequate circulation going to our extremities. And if we get a patient that rolls in and they don't have any circulation, we A, need to know that. So B, we can tell the surgeon, and C, possibly take them to surgery for an amputation or if we can't get blood flow back. And then mark, if you can, mark your pulses. I know that you guys have probably seen that done, but it's always important to mark, especially if they're hard to find. And in these types of patients, they're very likely to be difficult to find. So always mark if you can. Okay, and then watch for hypovolemic shock. Like I mentioned earlier, these patients are probably going to have lost a crap ton of fluid because of the burns. So they're going to be very, very, very high risk for shock, hypovolemic shock, if they're not already in hypovolemic shock. So obviously things like decreased level of consciousness, poor cap refills, watch for compartment syndrome. I don't know if you guys have learned about that yet. I think you learn about it in ortho. And which was like MedSurg 1, I believe. But compartment syndrome can be a very big thing because of all the swelling. Pale, cool skin, we've got that increased heart rate and hypotension, decreased urine output, increased respiratory rate, and then an increased blood glucose, I think is what the BG stands for there. Okay, and then second most common cause of death of burn patients in the first 24 hours is hypovolemic shock. So this is why getting fluids on board is really, really, really important. So the size of the burn, pre-existing conditions, and care determine the onset of shock. So like I said, if we can get a history on them, it's really important because if they've got other conditions we need to know about that can worsen it, then that's obviously important. And then obviously still continuously monitor for signs of shock even after. Okay. So when we, like I said a minute ago, LR or lactated ringers is the fluid of choice when we are resuscitating burn patients with fluid. These are very important things for you to know on this page, so write it down, commit it to memory. So for adults, we do 2 to 4 mils of LR times their body weight in kgs times the percentage of BSA burnt or TBSA. For children, it's 3 to 4 mils of LR times their body weight in kgs times the percent TBSA. And then from the time of injury, in the first 8 hours, we give 50% of what that calculation is. The second 8 hours, we give 25%. And the third 8 hours, we give 25%. Okay, so say we've got a 50-year-old male who weighs 70 kilograms. We got a 40% burn that occurred at 7 a.m. So our answer, say we're going to give the full maximum 4 mils. Okay, so 4 times 70 kgs times 40% TBSA. So 4 mils times 70 kgs times 40% equals 11,200 mLs. So remember, we want to give half of that within the first 8 hours. The second we give 8 hours is 25%, and the third 8 hours we give 25%. So it's 50, and then the rest of the 50 is over a 16-hour period. So we give 5,600 mLs by 3 p.m. because that's within the first 8 hours, and then we infuse 5,600 mLs over like the next 2 shifts, or 2,800 mLs per shift. So it's over the next 16 hours. It'll be kind of half and half over 2 shifts. Okay. So IV titration. So titrate IV fluid to a urine output of 30 to 50 mils per hour for burn patients. I think you guys have learned that 30 mLs is the minimum amount of urine output in a adult that we should ever see, unless they are like obviously a dialysis patient or something like that. But in an otherwise normal healthy person, we should always see 30 mLs or greater an hour. So 30 to 50 mLs an hour is how much urine output we should see. 75 mils to 100 mils per hour in adults with myoglobin in their urine is what we should aim for, and then 3 to 4 mils per kg per hour in children. We have to have a Foley catheter in place when we are fluid resuscitating, because if we don't, we have no way to know how their kidneys are and how adequate the fluid resuscitation is, because we can't gauge how many mils an hour of urine they're making. So if we are fluid resuscitating, we need a Foley. It's 0.5 mils per kg per hour for adults is what it kind of breaks down to. And then 1 mil per kg per hour for infants, up to 30 kgs. So rhabdomyolysis is a really common complication, depending, especially if you've got someone who's got a lot of severe burns or a very large TBSA. So rhabdomyolysis, remember, is this rhabdo is the breakdown of muscle, damaged muscle, and it causes damage to the kidneys. So we increase IV fluids to increase urine output to 75 to 100 cc's an hour. If urine is dark or red, we think rhabdo. We actually had a patient when I was with traditional students who had rhabdo not too long ago on PCU, and it was from working out too hard. Like he was training for the Marines, and he like way overdid it and caused himself to go into full blown rhabdo, and landed himself in the ICU slash PCU for an entire week. He was literally 21. So. Okay, so for neuro exams, we want to do a rapid neuro exam of the patient, assess their level of consciousness, their pupil size and reaction, and then we use the AVPU scale. So alert, response to vocal stimuli, response to painful stimuli. So alert, vocal, painful, and then unresponsive is what we assess for. Okay, so tubes and monitoring, if they have 20% or greater of burns, they're automatically going to get an NG tube and a Foley. Pulse ox should be on every patient no matter what, and a cardiac monitor. For ongoing monitoring, we are going to provide pain relief, small IV doses of morphine. Sometimes they may get dilaudid, things like that. There's different pain medicines, obviously, that we can give, and that's up to the provider. We want to monitor their vital signs frequently, assess their extremity pulses regularly, make sure they're up to date on their tetanus immunizations, prevent hypothermia, and then obviously provide emotional support. On burns that are greater than 20%, we want to be getting hourly urine outputs. And then the priority here is to stop the burning process. Okay, so wound management. So we want to keep the wound warm and dry. So with thermal, we cover with clean, dry linens. Electrical, we provide continuous cardiac monitoring and strive for a higher urine output because remember, their internal damage can be a lot worse than their external. So we have to think about the internal damages. So strive for a higher urine output of 75 to 100 mils an hour. And then for chemical, we continuously flush with sterile water. Flush, 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 and when you think you're done, keep flushing because we want to make sure that all of that chemical irritant and everything is out. Our initial labs and x-ray studies, we're going to get a hemoglobin hematocrit, we're going to check our electrolytes, our BUN, creatinine, things like that. You're probably going to get a full-on CBC, CMP, and a UA, so urinalysis. And then we're going to get a chest x-ray, an ABG, an ECG, especially if they are an electrical burn, and then we're going to check their carboxyhemoglobin, especially if they are an airway involvement of any kind. So a Curling's ulcer is something that burn patients can get. So it's an acute peptic ulcer, and it's a complication from severe burns that happens when reduced plasma volumes lead to sloughing of the gastric mucosa. So the patient is NPO. We give enteral feedings, so NG tube feedings. We give H2 inhibitors, so ranitidine, famotidine, aka Pepcid. And then we watch for abdominal distension, decreases in hemoglobin hematocrit, really mainly just to make sure that it doesn't rupture and doesn't start bleeding. So obviously we want to promote healing. So healing takes time. Time is literally the big thing here. Obviously they're going to require more nutrition, a higher protein count daily. Dietary or nutrition really needs to be on with these patients and following them because they're going to have to calculate how much protein and all of their extra calories and stuff that they need a day, and make sure that they're on the right diet. If they're on tube feeds, they can determine what type of tube feed is best for them based on like their counts and everything. Physical therapy is obviously super important. We don't want them getting contractures or anything like that. And then education. This is really going to be scary for the patient. I mean, I can only imagine, like when I did my clinicals with my students, or when I was a student and I did clinicals and had my kids at ACH, there was just a lot of education because people just didn't know, like the parents didn't know a lot of things, and I can't expect them to. Like if you're not medical, most people don't know these types of things. So it's just really important to be honest, be open, and just keep them educated. Obviously, we also want to promote rest, reduce pain and anxiety, give them good nutrition, monitor their fluid balance and electrolyte balances, and then make sure that their pH stays balanced as well. Debridements and cleaning. So debridements are going to happen when partial thickness burns are really involved, and they're debrided using scissors and washing them out really good. Sometimes they use a chemical such as sulfamylon cream, and it's specific for like burns and things like that. Deeper wounds have to be debrided in surgery and usually are followed by autografts or allografts, just skin grafts. And then cleaning is done with Hibiclens or antibacterial soaps. So dressings can include silver antimicrobial dressings, double antibiotic ointment, wound vacs are not uncommon at all. Silvadene, I have given or put Silvadene on many a times to patients, as well as the silver antimicrobial dressings, because silver has antimicrobial properties and it keeps wounds from getting infected as often. And then sulfamylon and BioBrain. So skin grafts are dead and damaged tissue, or they're mechanically excised or taken out. The top layer of donor skin is shaved off, and then it can be used as an intact sheet, so hands, face, joints, things like that. And it's usually covered or meshed to cover larger areas, so holes eventually fill in. So there's a couple different types of grafts. You've got allografts that are cadaver donated skin. They're temporary coverings until the patient is stable enough for autograft or until enough donor site can be harvested. Xenografts are from another species, such as a pig. Cultured epithelial autografts are skin grown from small samples of the patient's skin. So sometimes, like, they'll take it from their thigh if they need it, like on their arm, and their thighs are good because it's a larger area and it's not as affected. They are very expensive though. And then skin substitutes. I don't really can't think of anything really here. Allografts and autografts are really the two big ones that you're going to see for these types of patients. And autografts are preferred because it is the patient's skin, so their body is less likely to reject it. Because if you think about it, allografts, if it comes from a donated skin, it is a type of transplant and they can be rejected. So the autografts have a less likely chance of being rejected because it is already the patient's own skin. Not saying that it can't, but it's just less likely. Okay, so documentation and transfers. So obviously we want to get transfer records if we are getting the patient, or make sure that we are sending their records with them or sending them to wherever they need to go if we are shipping them out. So copies of x-rays and labs, EMS and nursing record, the physician assessment and history and physical, and then any kind of treatment given, meds given, fluid resuscitation been given. Those are all things that need to be included in documentation. So the transfer process. So we never delay a transfer. These patients do not have time to be delayed, especially if they are a critical burn. They need a level 1 trauma center with a burn unit specifically. So really for the transfer process, we want good physician to physician communication and then good nurse to nurse communication. So give good reports, make sure your doctors give good reports, things like that. And then transfer via either ground or air. If they're super, super critical and time is of the essence, a lot of the times these patients are going to go by air because they sometimes don't have an hour or two to go with a ground trip. All right, so now we are going to hit into organ donation. So those are our objectives. Okay, so the nurse's role in organ donation is early recognition of a potential donor, referring them to organ procurement organizations. So like here we use Mid-America, and there's different regions, and I think I have a picture of the different regions at some point in this PowerPoint, but there's different regions, and each region has a different procurement service that they utilize. Ours is Mid-America. We want to ensure the family's legal right to be offered the option of donation, serve as a donor and family advocate. And when I say donor, it's the patient. Understand medico legal issues that can happen, comfort the grieving family, and support them in whatever decision they make. Organ donation is not for everybody, guys. Even though we as nurses know the impact that it can have positively for other people, some families just can't handle it. I'm so thankful for organ donors because my best friend would not be here had it not been for a family donating their 3-year-old child's organs. And she got a liver transplant when she was 5. So it takes a very special person to be able to do that. Um, but not everybody can bring themselves to do it. So we just want to support them in whatever decision they make. And then assist in the management of the donor. So we'll talk about some management of if a patient is a candidate and the family does want to donate, what we have to do to keep their body in shape to be able to donate and their organs still be viable. And I also want to mention here, I think I have it later on too, you as the nurse should never be the one to initiate the conversation of organ donation. There's usually something in the chart that you have to document on like every shift, and it'll say like this patient is a candidate, like it's a criteria that you go through and check mark. And it'll say if the patient is a organ donor candidate, and if they are, it'll tell you to contact your procurement service, and then you will just call Mid-America, your Mid-America rep, and your unit should have that information. You'll probably get it in orientation if you work at an ICU. Sorry. But just know that if you are approached by the family, by all means say, let me get you, I completely am supportive of your decision. Let me get you in contact with the right people. Let me go make a phone call to them. And they're usually in the hospital like within an hour or so of that phone call being made to them to talk to the family. Okay, so issues related to organ donation. So 98% of all adults have heard about organ donation. 86% of adults have heard of tissue donation, and 90% of Americans say they support donation. But only 48% of licensed drivers have committed to organ donation. So this is important to note right here. Driver's license, when you state that you want to be an organ donor, when you sign your driver's license, that is first person consent. So if something happens to you, that is in the organ donation like registration database, and that is a first person consent. I had a patient, or he wasn't mine, but he was on the same unit that I was on, and it was like the nurse that was next to me. It was a younger guy. He had an accident. He was an organ donor. Had designated on his driver's license that he wanted to be an organ donor. The family came back and refused. Well, since he had already stated that that was what he wanted, that was first person consent, and so that is what they went with, and the family did not have any kind of say. Like it was what it was. It was basically like him being able to wake up and say, yeah, donate my organs and tissues, and then back to the state that he was in. But that is first person consent, so nobody can take that away, is what I'm trying to say. It can get very hairy. The family was not happy with that answer, but since that is what he had designated when he was of sound mind and body, that's what stuck, because that is a legal document. Okay, so some stats. So attitude polls suggest that we are more likely to donate our family's organs than our own. African Americans and Hispanics are significantly less likely to donate. They're more likely to donate organs if they are less than 55 years old. Most religions do support organ donation. Over 20 different organs. So sorry, I keep yawning, guys. Over 20 different organs and tissues can be transplanted or used in research, and one person will be added to the national waiting list every 9 minutes. Think about how many people that is in one day. And then 17 people will ultimately die waiting for an organ on that list. 35% of medically suited donors are lost due to family refusal. 10% meet organ donor criteria, and 95% meet tissue donor criteria. The most common cause of death is trauma, and then 98% of all organ donors die in a critical care unit. 20% within 6 hours of admission, and 50% within 24 hours of admission. So, 1968, the Uniform Anatomical Gift Act happened. The 1978, the Uniform Brain Death Act happened. 1980, Uniform Determination of Death Act. 1986, the Omnibus Budget Reconciliation Act. And 1984, the National Organ Transplant Act happened. So the big thing here is the 1968 Uniform Anatomical Gift Act is what made organ transplantation able to happen. It legalized it, is what I'm trying to say. So 1968 Uniform Anatomical Gift Act is what legalized organ donation to happen, or to be able to happen. So these are just some national wait lists. This is the national wait list additions through April 5th. So I pulled this just a few days ago. And these are the amount of people that are currently on the wait list. And you can see like the amount of people added each year. So there was a little bit of dip here, but we've pretty much trended upwards every year. So these are the transplants that have happened through April 5th, 2024 by the year. So these are over here, that is those numbers. So 2019 total. So living and deceased means like if the donor was living or if the donor was deceased. So like you can donate part of your kidney, or you can donate a kidney or part of your liver as a living donor, but I think everything else, and skin, but I think everything else comes from a deceased donor, because obviously you can't donate like your heart and things like that and live without it. So those will come from a deceased donor. So obviously we can see deceased donors make up a very large part of the donor transplants. Okay. So this is a 1 year, 3 year, and 5 year survival rate. So I kind of want us to look and see what the highest percentages are within those 5 year ranges. So I would very much memorize these 5 year survival rates, because this is really what, obviously 1 year is important, but we want to look at long term what the survival rates are for these types of transplants. So obviously a kidney pancreas, so a kidney pancreas transplant has an 81%, heart lung has a 49%, pancreas alone has 59%. Lung, it's counting for single lung and double lung transplants, is 52%. Liver is 72%, kidney is 78%, intestine is 49%, and heart is 77%. Okay. So the National Organ Procurement and Transplantation Network, UNOS, is what promotes, facilitates, and scientifically advances organ procurement and transplantation, and it administers a national allocation system. So there are patients who are waiting on the organ transplant list, and that they basically keep track of that list. They are the ones who started that list and the organ donation whole process, and that is who the list, end quote, goes through. If you hear someone say I'm on the list, that's the list that they're talking about, is the organ transplant list. Okay, yeah, here's our maps. So when I was talking about regions earlier, we are region 3, so down here. And as you can see, we are pretty much bordered by different regions on just about all sides of the state, it feels like. Louisiana and Mississippi are the only two that are in the same region as us. Tennessee is in a different region, Missouri is in a different region, Oklahoma, Texas. They're all in different regions. So, depending on what region you are, it depends on what procurement service you use, and depends on um, or can depend on the donor that you get, because we can't, depending on the type of organ that somebody needs, you can't send an organ halfway across the country if it's like a heart or something like that, because those have to be transplanted. You've got a window, and a lot of the times they can't meet the time frame from harvesting the organ to transplantation of the organ into the donor. So these regions are set up for those reasons. So for the matching criteria, they look at the medical urgency, a tissue match, blood type, how long the patient has been waiting, organ size, immune status, and then, like I said a minute ago, the geographic distance. Because depending on the organ, it's going to depend on how long they have to get it into the donor. When I say medical urgency, I think you guys probably realize what I'm talking about there, but it's like, oh, I'm number 1 on the list, or, I'm number 3. I just moved up from number 40. And it's usually because there's been a change in status for the worse, like not for the good. The patient has declined and they have moved up, because that is literally the only thing that is going to save them is a organ transplant. So they get moved up based on the medical urgency of their case. Okay, so we have categories of organ donors. So we have a brain dead donor, a donation after cardiac death, and then obviously a living donor. So a brain dead donor is kind of the most common, it seems like. So the prereqs for the clinical evaluation, so they have to meet a certain clinical criteria. They have an ancillary test, so they have to basically be pronounced brain dead by a physician, and there's usually 2 physicians. They come in and they do several different type of tests, like a corneal reflex test and things like that. And then they will do what we call a brain death scan, and it is a scan that is done in nuclear medicine, and it looks at the activity of the brain. And in somebody who is brain dead, it is completely black on the scan, whereas it should be white. I'm pretty sure I'm telling you guys that correctly. I do know that it's completely black if there is no brain activity. I think it's supposed to be white if it is a normal, like if the person is alive and awake like you and I are. So that is how, or some of the things that they use to determine brain death. They are pronounced dead or brain death at the time that is pronounced. Like that is their time of death, is when brain death is declared. We can have donation after cardiac death, so there's no recovery from illness expected. They don't meet the brain death criteria, but they're dependent on life-sustaining measures. And then living donor is obviously someone who's in overall good health. They don't have any kind of major diseases like diabetes, cancer, heart disease, kidney disease. Their blood type is compatible. They're in a healthy BMI. And living related donors typically provide the best long-term outcomes. So for the donation process, we want to identify and refer, evaluate, consent, donor maintenance, and recovery. So for step 1, we identify the hospital personnel. We refer to organ procurement organization. They're evaluated by the organ procurement specialist for donor sustainability or suitability, and brain death is declared by the physician in this state or step. So for brain death, their heart is beating, the patient's heart is beating. They have acceptable organs and tissues. They are on ventilatory support. They go to the OR for surgical removal, and then tissue recovery is followed by organ donation. For cardiac death, the patient has no cardiac or respiratory activity. Um, Acceptable donations are typically just tissues, because most of the time, if they've been down too long, they're not perfusing and their organs aren't viable anymore. That's why with brain death patients, we have to keep them on life support, and we have to keep fluids and stuff in them. With cardiac death, their body must be kept cool before tissues are removed. So a lot of the times these patients will go to the morgue. If the coroner can't come and get them, or the funeral home can't come and get them, if they are going to donate their tissues, because their bodies have to be kept cool to help stop the decomp process. And then removal is based on which organs are able to be recovered. So, brain death, like I said a minute ago, is a legal declaration of death. It's complete and irreversible loss of brain and brainstem functions. It can be diagnosed in full term newborns older than 7 days. And then the time of death is documented when brain death is declared. So, when brain death is declared, that is their time of death. The 3 cardinal signs or symptoms of brain death are unresponsiveness, absence of brainstem reflexes, and apnea. So when you do like a ventilator CPAP trial, and you put them in like CPAP mode, they usually are just apneic. They don't breathe at all. And that's one of the cardinal signs. So determination of brain death. So known cause of death. We know that we know what the cause of death is. We know that the condition is irreversible. Their body temperature is greater than 90 degrees or Fahrenheit, or 30 degrees, 35 degrees Celsius. Their pupils do not react to light. They're fixated, they're dilated, fixated, all that. No spontaneous movement in response to external stimuli, so like your sternal rubs. No reflex activity except that that we elicit ourselves by the spinal cord. And then apnea in the presence of hypercapnia. So, like I said, those CPAP trials. So step 2, when we are evaluating the patient, we obviously are testing them for transmissible diseases, and then continued evaluation for organ stability and suitability are the 2 big things that happen here. Step 3 is consent. The medical examiner or coroner releases the body. Death is explained to the family. We usually allow time for the family to understand the reality of that death, let them spend time with the patient. Donation options are introduced and discussed, and then consent forms are signed and witnessed. So you as a nurse can sign as a licensed registered nurse, not as a student. But here in just a couple months, you will be able to witness a form of any kind that is needed for purposes like this, for example. So consent goes in this order. If the patient is not a first person consent, like designated on their driver's license that they are a organ donor, it goes spouse, grown adult children, parents, and siblings. So when we present the option of organ donation, this is a separate discussion of death and donation, and it's called decoupling. So we need to be using a sincere and sensitive approach. We use terms like recovery instead of harvest, and terms like life support may confuse a family that's dealing with death. So we use mechanical ventilation instead, because we have to keep them on mechanical ventilation if we are going to harvest or recover their organs. We support the family, like I said earlier, in whatever decision they make. And typically you as the nurse are not the one to bring this up to the family. You typically will notify the organ procurement service, and they will be the ones to initiate this conversation. Now, like I said, if a family member approaches you about it, that's a little bit different. So you will just say, I fully support you. Let me make that phone call and get things, conversations going for you. So, like I said a minute ago, the next of kin goes spouse, adult child, parent, adult sibling, grandparent, and then a legal guardian. You do need to know this. Okay, so donor family considerations. So, failure to understand that brain death is death. So, a lot of the times they don't understand like that brain death is death. They're like, well, their heart's beating. Their heart's only beating because we have them on a mechanical ventilator and we are like they're on life support. That's the only reason, but there is no brain activity. So, if we pull them off, they're going to be apneic and they're going to eventually die, like a cardiac death. They have a fear of an additional expense. Everything that is like if a family decides to donate their loved one's organs, it is all paid for by the organ procurement service. Like it is nothing out of pocket for the family. They have a fear of mutilation of the body, and I think it's very similar to now if they start donating tissues and things like that, and skin, that can be a different story. And it really just depends on what all they do and don't decide. Some people don't want to donate tissues, but they're fine with donating organs because they want to have an open casket funeral. Sometimes I have seen them do an open casket funeral and then like just for the goodbyes, or at least do a viewing service or some kind of visitation, and then after that they take the body back to harvest the tissues. So things can be done to accommodate the family. That just has to be worked out with the organ procurement service, but they're very good about accommodating where they can. They have a fear of unfair or unethical organ allocation. So we just really reiterate that we go by the organ procurement service goes by like the national list, and that there are steps legally that they take to ensure that it goes to the right person. They fear that a loved one may suffer pain after suffering enough. They're not in any pain. They're very much, to a degree, medicated, but a lot of the times they don't understand like that they are brain dead, and so they are not experiencing pain. But this is where we let these conversations happen with the organ procurement service member, because they're trained on what to say and how to explain all this, whereas like I would not be able to probably explain it how it needs to be explained, and in a way that is very sensitive, just because I've not had the extensive training that they've had to have those conversations. Okay. So step 4 is the maintenance phase. So we want to stabilize hemodynamic functions and maintain viability of organs. And then the recipients are identified and the transplant teams are mobilized. So really here, our urine output for these donors needs to be 100 mils per hour or greater for adults. Kids are different, but in the adult world, which is what we're doing right now, 100 mils an hour or greater for urine output is what is needed to be considered hemodynamically stable. And then the focus of donor management is to maintain blood pressure, maintain a normal glucose level, normal temp, treat any kind of anemia, treat coagulopathy and thrombocytopenia, provide adequate ventilation, treat polyuria, and then maintain an acid-base balance. Okay. For recovery, so the operating room procedure for organ recovery, it's done in an OR. It's a sterile environment. Procurement and preservation of the organs happens. If they're going somewhere outside of the hospital, they usually go into a big cooler that's labeled like human organ, and it's on ice and all this other stuff. Tissue recovery follows organ recovery in a sterile or clean environment. Most of the time, this happens in the OR right after the organs are procured. And then a possible autopsy and body released for burial. So, tissue histocompatibility. So, survival of grafted organs depends on the similarities in the genetic constitution of the donor and the recipient. So, this is like the human leukocyte antigen or HLA. So, donors and recipients are both tested, and then it is put into the database to see who is most compatible, to see who is the most compatible and will have the least likelihood of rejection. So, if you are taking care of somebody post transplant, there's a couple things we need to go over. So, obviously, factors for determining recipient selection is going to be that blood typing, cross matching, tissue matching, that geographic location, the patient size and the donor size, and then their need or their medical necessity. Immunosuppressive agents. So they're going to be on immunosuppressive agents as well as several other meds, but obviously immunosuppressive agents because they don't want these patients to reject their organ. So cyclosporine is the most preferred because of its ability to keep killer T cells at bay. But you can also see Imuran, prednisone, and Cellcept. I've given Cellcept multiple times to patients who have had post transplants and things like that. My best friend still takes prednisone. It's a very, very low dose prednisone, but that is what she converted to years later. She obviously can't remember now what she took as a kid, but I'm sure her mom does. But we lived together in college, and I remember, going through and getting her prescriptions from time to time, and it was always prednisone that I would pick up as well as a baby aspirin, and I think there was something else. But they also are probably more than likely going to be on some type of anticoag just because of the risk of clotting, and they don't want them to clot. So those are the two big things. But cyclosporine is the most preferred because of its ability to keep killer T cells at bay, at least in the early stages. Okay, and then we have phases of treatment. So we have induction, maintenance, and anti-rejection. So that induction phase is going to be that transplant in the OR. They're going to get monoclonal antibodies. And then maintenance is that long-term combination of meds, those corticosteroids, those calcineurin inhibitors, and antimetabolites. And then anti-rejection is obviously long term. Like I said, she had hers when she was 5, and we're a month apart in age, and she's 28. So she's obviously done well. They do still have to go get labs drawn. I think her labs are every 6 months. Or it's every year now. I can't remember. But obviously it's going to be more frequently the closer post-op they are, just to make sure that those levels don't rise. I think she did have a scare like one time when when we lived together, and it was just because she'd been sick and she had to go like every 2 months and like get it drawn for like a year, every 2 or 3 months. But everything was fine. She'd just been really, really sick with like a really bad stomach bug, and it made her levels a little funky. So anyway, okay, that is it. I hope you guys have learned all about organs and burns. But if you need anything, just email me and I will get back with you. Bye, guys.